challenge for us. That's not just my opinion. There is medical literature around this issue, and basically in some ways they call us the weakest link. And essentially, there are multiple chains in the whole link of how to plan and treat patients. Target delineation is only one of these, but it can have massive impacts downstream after if there are errors in that stage. Many of you may have seen this type of image before. Ideally, what we are striving for is high accuracy and high precision. We don't want to be accurately imprecise or precisely inaccurate. And this is an important issue, similar to the slide that Neil put in. We can see that essentially in the past, what would happen is that with less of the technology, we would actually have very large margins, and at radiation oncologists, we could actually hide behind that in the setting that, even though if we were completely accurate about our target delineation or target aiming, with large CTV and PTV margins, the chance of actually missing the target was low. The doses were lower, so the impact against the normal tissues was lower. But that is no longer the case. We are treating patients to higher doses, more conformal plans, and with now the advent of IGRT image guidance, if you actually target, an imprecisely contoured target, you will actually hit that accurately, but you will miss. And this is sort of what happens here. So you have a geographic miss, but not in terms of your target, but in terms of the truth. And so this is where this is how the interaction with technology with contouring comes into full force. So to be fair to us as radiation oncologists, it is a very vexing problem because there are multiple inputs with regards to contouring. And this is sort of a slide that sort of demonstrates the true complexity of the problem. So you have a new case, there are various things that go into trying to determine what the targets are, including history and physical exam, the pathology of the cancer, various diagnostic imaging, and previous natural history of the tumor that you would know. And then there are new technologies such as 4D CT and respiratory gating, like in terms of some of our chest treatments. Even other things like window and level settings can have impacts in terms of the contouring. There is, once again, intra and inter-physician variability issues that can occur and have been documented in the literature, and I'm going to go into a little bit about that as well. I've also listed here training, so basically how you were taught or the experience that you've had in the past can impact how you're going to contour a certain case. And then more and more, there are new types of auto-contouring or deformable registration contouring algorithms that might skew your contours in a certain way. There have been cases where people have gotten together to try to define best practices, and so more and more of those are going to have impact as well. And then I also mentioned in the bottom here, case 1 to n-1. So basically, it's the radiation oncologist's past experience. How did you do the last case or the case before that? Were there cases that you had bad complications that might change what you're going to do? So once again, this is it's a multifactorial problem that does lead to this variation that we do see. In terms of variability, I just wanted to give some examples in the literature. I'm not going to spend a lot of time because there are a lot of examples in the literature in terms of inter and intra-physician variability. On the left here, you can see an example of a European study looking at variation within lung cancer contouring. And then on the right, also another European paper. So on the left, it has to do with treating the variability in terms of primary tumors. And I think there's a lot of people that think that actually nodal, like if you see a node, that you would have less variation. But actually, in these papers, we actually demonstrate that the nodes do vary. And a subsequent paper that we published in the Green Journal recently actually demonstrated that the nodal contouring was actually of higher variability than the primary contouring. And this also extends to other things that you wouldn't think about in terms of palliation. So this is an example from Toronto in terms of a large periaortic tumor. And even in a palliative setting with a tumor like this, you can see that there's wide variation in terms of contouring. Some people contouring more of the tumor itself. Some people going all the way back to treat the whole vertebral body. and you can actually see this manifested in other planes as well. So and the thing is, as we get into more IGRT and IMRT for even palliative treatment, these variation differences will have a part to play as well. So what kind of things have been done in the literature to try to reduce this variability that we see between and among physicians? So some of it's technological. In terms of lung, one of our favorite things to do is order PET scans for our patients. And here's an example once again from Europe, looking at variability pre and post PET. Once again in one case, and here's a second case. You can see a lot of variation in terms of contouring, decreased variation in terms of once you have PET information. One thing to be cautious about PET is that it does reduce variability, but it's still only a representation of the truth. There hasn't been real good pathological confirmation of what SUV you should be using as a threshold. But if one of the goals is to reduce variability, type imaging can assist us in that goal. This was the paper that I mentioned just previously with regards to looking at nodes and primaries and showing that nodes have more variability. But the reason why I put it up here is the fact that actually doing the 4-DCT in itself for lung cancer can actually reduce variability. So we've actually shown that actually just the aspect of having more data does allow the variation to go down. Other individuals or groups of individuals have looked at trying to define best practices with regards to contouring atlases. Now, there are many contouring atlases available in the literature or online. I put two of the ones that I use the most up here. On the left, there is the prostate bed RTOG atlas, which defines either basically prostate bed contours with rules and some clinical examples that you can see. This is not the only contouring atlas that's available. There are actually, I think, a total of 4 prostate bed consensus guideline atlases available in the literature, which then begs the question about which one to use. On the right, a recent publication looking at lung SBRT and lung contouring. You can see quite an extensive atlas that was published based on multiple individuals that are in the field to try to define best practices with regards to contouring. Once again, with the goal of trying to reduce variation in the community. This also extends to head and neck, and there are head and neck atlases available. One recent paper out of the United States looked at using auto-contouring and auto-segmentation using a deformable registration algorithm to try to reduce the amount of variation between physicians, and they were able to see some benefits with regards to that. Once again, that would require further validation to make sure that with reducing the amount of variability, you're still getting accurate contouring that is clinically relevant and clinically appropriate. So a lot of the traditional technology I've talked about in contouring atlases and PET and et cetera, but there's a whole other area that actually there's not a lot of literature on, but I think is probably just as equally important, and that has to do with ergonomics. How we actually contour may change over the time, and there is some preliminary data with regards to a randomized trial looking at, more traditional mouse-based versus pen-based contouring, and these can have impacts in variability. And similarly, although in its infancy there is some research with regards to training of physicians with regards to contouring, this paper in the Red Journal out of the Toronto group looked at a randomized trial between looking at 2 different types of contouring teaching and to look at the impacts of those contouring differences. In this case, the randomized trial didn't show a difference between the 2 arms, but I think more and more of this type of data is very useful to try to help teach the next generation of contourers in terms of consistent contouring. Now, in terms of metrics